Welcome everyone who has tuned in, colleagues from here and from, I see a few from the UK as well. This is our first online deaf policy event since we've stopped having our physical events on campus. I am absolutely thrilled that this one is joint with the Centre for Global Development, CGD, and the Labour Mobility Partnerships, LAMP, which is a new organisation incubated out of CGD. As the first one of hopefully many events, please do expect a few potential hiccups. Please let us know what works well and what doesn't, and please do come back for the future events, which we'll be announcing quite shortly. My name is Ryan Edwards. I'm a fellow at the Crawford School and the Deputy Director of the Development Policy Centre. If you're not already signed up for our Labour Mobility newsletter as well, please do visit our website and do so. So our first speaker today will be Helen Dempster. Helen is the Assistant Director and Senior Associate for Policy Outreach for the Migration, Displacement and Humanitarian Policy Program at CGD. And Helen is joined by Rebekah Smith, who is a non-resident fellow at CGD working with the Migration, Displacement and Humanitarian team. She is the founder and interim director of LAMP. Today's talk will draw on two great CGD papers, the first on promoting new kinds of legal labour migration pathways and the second on global skills partnership. And it extends a recent blog post that the two have done on the same topic. We'll aim to present for around 20 minutes and then open up to a discussion. Over to you, Helen, if you would like to share your screen, and I will mute myself for at least the next 20 minutes.
Do my best. All right. Is that working?
Yes.
Excellent. Well, thank you very much, Ryan, and to ANU and the Dev Policy Centre for inviting us to come and speak. Good morning, good afternoon, whatever day or time it is right now. Thank you very much for coming to speak with us. This is the subject of our discussion today. As Ryan just mentioned, it's something that both CGD and LAMP have been thinking about a lot since the COVID epidemic really started to spread. You probably will have seen a number of pieces in the news recently about migrant health workers around the world, and we're thinking about ways in which to leverage this opportunity and this new renewed interest into trying to increase health worker migration going forward. So just a little bit about us. So Ryan's already introduced us a little bit, but I thought that I would briefly go into what the MDHP program does. I know it's a bit of a mouthful, but we work across all three of those subject areas. So we've got our three project aims up there at the moment. If you do want to get in touch with us, feel free to send me an email after this, and all of our work is online. But I thought, given that LAMP is a new organisation, I'll give Rebekah a few minutes to introduce her organisation and what they're planning to do going forward.
Thank you, Helen, and thank you, Ryan. As Ryan has already said, Labour Mobility Partnerships is a new organisation that for the last year has been incubating inside of Centre for Global Development. We're very much founded on a foundation of all the solid research that CGD has been putting out over the years on labour mobility. Our mission is to build systems which connect workers with jobs abroad in response to really just the vast demographic need of OECD countries, which will really outstrip the capacity of our current labor mobility systems. So we have three key functions that we look at towards building these systems. The first is brokering relationships between partners, those being governments, mobility industry, and sectors of employment that are needed to really build a complete labor mobility system, providing technical support on the design and implementation of these systems, and then conducting research and advocacy on the impacts and design of labor mobility systems. So as Helen said, if you're interested in learning more about our work or anything else about LAMP, please do feel free to reach out.
Awesome. So we're going to kick off with some definitions, as all good presentation does. But I thought it'd be quickly worth describing what we mean by health worker in this case. So we're using the WHO definition, which includes doctors and nurses, but also other roles that are essential to the running of the health system, like midwives, care workers, and support staff. I've got a couple of examples down there. So in the world, there are about 60 million health workers today. About 2/3 provide health services, and the other third are in those management and support functions. But as you'll see later, that's not nearly enough, nor are those numbers evenly distributed. So the WHO estimates that by 2030, we will be short 18 million health workers, mostly in low and middle income countries. But of course, without these workers, we're going to have no hope of achieving the Sustainable Development Goal of universal health coverage. So, I'm sure this is not news to all of you, but I always find it staggering when I see the statistics that in most high-income countries, migrants make up a really large share of health workers. So this graph shows the foreign trained breakdown between doctors and nurses across the OECD in percent. Where there isn't a bar, it's because we don't have data. But thankfully, we do have quite a lot there, and it paints a really stark picture. So as you can see today, 1 in 6 doctors across OECD countries studied abroad. And in the last decade, the number of foreign-born doctors and nurses in the region grew by 20%. So migrants make up 12% of the 1.9 million strong UK health workforce and 17% of the 12.4 million strong US health workforce. Of course, foreign-born health workers may have studied in the country they migrated to, not in their home country, perhaps because they moved when they were young or because they moved for study. But regardless, this shows us that health systems in high-income countries already rely on migrant health workers, and that need is going to increase. However, despite this reliance on foreign-born health workers, high-income countries have historically resisted increasing health worker migration. And we would argue there is 2 main reasons for this, although of course there are many more. The first one is they worry that these workers will not have the required level of skills. So this is a concern you often hear from nursing unions and other healthcare guilds. They're worried about foreign trained health workers not providing a high quality of care due to differences in training, language, and culture mainly. They feel that recruiting foreign workers merely serves to avoid issues within the system, which prevent locals from taking on these roles, and in so doing compromise patient safety. So as a result, there are strict regulations in place in many countries as to qualification recognition, credentialing, additional training, and language requirements. What I find really interesting, though, is when you dig into the research about this, there is no discernible difference in patient outcomes between foreign trained and native workers. That's just one example from a US study, but there are many around the world. So this would seem to tell us 2 things. One, the fear seems to be unwarranted about this level of skills, and or the restrictions that are currently in place are having this desired effect of making sure that we have quality workers in the system. Either way, we would argue that the system could be extended to new workers without worrying too much about this first criteria. The second is that, and more importantly for our case today, is that they worry that facilitating health worker movement would deprive countries of origin of their much needed health workforce. So that's something I talked about before, this massive shortage of health workers in low and lower middle income countries. Should we really be trying to remove these health workers from these countries? So this obviously becomes an ethical question, one that the WHO sought to address in their 2010 Global Code of Practice. Basically, the Code of Practice discourages active recruitment from 57 countries where they've identified a critical shortage of health workers. So a critical shortage is when there's less than 2.28 health workers per 1,000 of population, which is a fairly arbitrary statistic, but it puts in that bracket most of sub-Saharan Africa, most of Southeast Asia, and some of Latin America. Now, importantly, this number is decreasing. So if we applied the same criteria to today's data, there would only be 43 countries that fall into that category. Some of them who've moved out of the category include India, Morocco, and Indonesia. So countries really are improving now and increasing the stock of their health workers. However, some high-income countries have interpreted the code as banning all health worker recruitment from those countries. Doing so, they argue, would lead to brain drain. So as I said before, the removal of limited qualified health professionals. It would be unethical, they argue, to remove those workers. And we completely agree. That's why the code precludes poaching of workers by recruitment agencies. It doesn't preclude bilateral agreements between 2 equal parties, and this is pretty explicit in the code. These agreements usually include some kind of mutually beneficial arrangement. So the high income country may get workers, but the low income country gets some form of investment in their healthcare system or health workforce. So as an example, there's a nursing bilateral agreement between the UK and the Philippines at the moment. The Philippines provides health workers in exchange for workforce development and best practice sharing. Now, this nuance is not well understood by many countries. You often hear this as an argument why we shouldn't be expanding health worker migration. And the WHO code is often used explicitly to ban new agreements. The CGD is going to be putting out a new piece of research that the WHO actually commissioned to try and redress some of these issues, which I'd be happy to send once it's published. But I would like to point out that when you hear this argument, there are definitely ways around it, and that way is bilateral agreements, which we'll go into in a little bit more detail soon. So the second kind of main reason why there isn't so much health worker migration is that much of the health workforce, which includes things like technicians and care workers, is deemed low skilled in high income countries, which obviously makes migration a lot more difficult. So as an example, in February of this year, actually, the UK unveiled its new points-based immigration system to govern migration once the UK leaves the EU. So under the proposed new rules, if you aren't able to earn over £25,000, which is how many Australian dollars? $40,000, I think, per year in the UK, you won't be allowed to enter unless the government deems there's a shortage in that particular sector. So many government officials have de facto bracketed people under that earning threshold as low skilled. Now, of course, this earning requirement covers many people that are now deemed as key workers by the UK government in the face of the COVID pandemic, including paramedics, nurses, carers, and midwives. And this is my favorite quote that's come out of the UK press in the COVID coverage at the moment. This is a Brexit supporting member of parliament who recently said in parliament to the new Home Secretary, so the person in charge of immigration policy, one of the things that the current crisis is teaching us is that many people that we consider to be low skilled are actually pretty crucial to the smooth running of our country and are in fact recognized key workers. And he actually called on the Home Secretary to revisit this points-based immigration system in light of what we've learned during the pandemic. And I think what's interesting about this is that COVID-19 has shown us that barriers to health worker migration are surmountable in times of crisis. So you're seeing over and over and over again, the softening of restrictions on foreign trained and born health workers in high income countries to try and deal with this crisis. So workers have been flown in, like Chinese, Cuban, and Albanian doctors recently moving to Italy. Internal restrictions have been lifted. So you're seeing refugee doctors without recognized qualifications are being called up in Germany and having their recognition fast-tracked in the UK. You've seen New York allowing foreign doctors to work, and Australia is lifting working hour caps on foreign trained nurses. These examples show that when desperate, high-income countries are willing to overlook the barriers above. And we would argue that they're going to become a lot more desperate. So I'm going to pass it over to Rebekah.
Thank you, Helen. Yes, as Helen said, when we were walking into this crisis, key destination countries, the key countries where we're currently really seeing the outbreak of COVID-19, were already facing significant shortages of health workers. So you can see right there that we've just put as an example, nursing shortages across a selection of countries where there's currently an outbreak. And you can see that over just the coming handful of years, over the next 3 to 5 years, really, we're seeing significant nursing shortages across a number of key destination countries. And that's just one of kind of the many different types of health worker shortages that we were already facing walking into this crisis. We've already seen examples of ways in which those shortages were binding even pre-COVID-19. So for example, US emergency rooms are often, there's many cases in which they're not actually able to fill all of their beds because they're not able to staff them due to these shortages. That's the situation we were in, months ago. This is in fact what those of us in the mobility industry have been talking about for many, many years. Health workers have been on the migration community's radar for really years and even decades now as a sector that we need to be paying attention to, a sector that we knew was going to become increasingly important in the future. I guess the easiest way to say it is that future is here now. So while we already had shortages at the beginning of COVID-19, during COVID-19, those shortages are becoming increasingly binding. As doctors and nurses get sick themselves and are forced to exit the labor force, they're forced to stop working. So you can see there the number of infections of doctors and nurses in some of the key outbreak areas. Doctors and nurses who then, of course, had to exit the labor market. And given that these countries already have shortages, these countries do not have a supply of health workers to replace these workers as they have to stop working. Which means that throughout the outbreak period, you're having more and more health workers exit the workforce and not stop working, which means that your workforce is effectively shrinking at the worst possible moment, really. As Helen said, we're already seeing some responses to that. In terms of this specifically, the example I would think of would be Chinese doctors who, as the outbreak subsided, moved over to Italy to help them in their response. We'll talk about that more in a minute. However, we can also expect health worker shortages to be increasingly binding in the long term. So that's right now. In the short, immediate term, we can really feel these shortages and how binding they are and how critical their impact is. But in the long term, first, we have a rising elderly population in almost all OECD countries. And what this means, of course, is that you have a smaller labor force while you have a larger population of elderly care or elderly people requiring more intensive health care. So we can expect to see that make these numbers on the left even larger in terms of the number of health worker slots that we need to be filling. But something else that's not actually reflected on this slide is that even prior to COVID-19, there was a consensus in the science and health community that we're likely to see an increasing number and frequency of pandemics, which means that it's quite possible this is not the only pandemic we will all live through. And which means that when the next one hits, we would not only have a larger elderly population, but if not addressed, much more critical health worker shortages. So while we were caught, let's say, unaware during the COVID-19 outbreak, we can use this moment to begin thinking of how we could be better prepared, both for this inevitable demographic future and for the quite possible future in which there are actually more pandemics as well. Oh, next one. So, Helen and I are going to talk about two responses to what that could look like. I'm going to focus on what we could do right now. So one of the things that we know is that researchers and scientists are saying that the evidence appears to be accumulating that COVID-19 outbreaks are both seasonal and cyclical. And what that is, so what you can see on the graph right there is a map of the current outbreaks, and you can see that they're geographically concentrated at a specific latitude. Scientists seem to be predicting that that might shift as the seasons change. You might see outbreaks subsiding in the northern hemisphere and emerging in the southern hemisphere. What that means is that demand for health workers right now will be moving rapidly. So as you have a health workforce responding to an outbreak in one area, as that outbreak subsides, the need for those workers might also subside, or perhaps a better way of putting it is those shortages might become less binding. On the other hand, at the same time, you might expect to see outbreaks in other geographic areas that themselves are experiencing their own shortages, especially as we move to the southern hemisphere, which, as Helen has already said, is also facing large shortages. So what that tells us is that in this moment in history, we could prevent unnecessary deaths by allowing health workers to move rapidly to wherever they are required at the moment. So this effectively would be creating a global emergency response team of health workers in response to COVID-19 outbreaks. Because ultimately what we're seeing right now is just the critical impact of health worker shortages in a very tangible way that in this case could mean the difference between life and death for some of the people who get infected. So one of the things we can do in the immediate future would be just to allow health workers to move where they're needed at the time. Helen has already given you some examples of how this is happening, and I've just mentioned the example of Chinese workers moving on to help the response in Italy. So effectively what we're proposing is exactly that sort of dynamic, but it's just currently happening at very small scale. What would it need to happen for it to happen at sufficient scale? It's quite tricky. Well, mobility is always tricky. Mobility of health workers is always trickier. Rapid mobility of the type that we're discussing is incredibly complicated. But there are three effective elements that you need to make it happen. The first is that you need flexible visa issuance. Visas are not designed well for rapid mobility. It's a time-consuming process. Workers are often, especially skilled workers like health workers are often tied to a specific employer for a specific period of time, and our labor mobility pathways are not particularly flexible to allow the movement of the type that we're describing. So we would need to have a visa system that allowed for that. Now, it is possible, for example, if you think about the movement of humanitarian response workers, which is effectively what we're describing with this, there are visas that allow for this kind of movement, and mobility systems have created ways for them to move legally and rapidly in response to crises, which is effectively what we're describing here, but we would need to be able to deploy that at scale. And then we would need to be able to deploy it while recognizing and vetting the skills certifications of these workers. So as Helen has already mentioned, one of the critical elements key considerations, let's say, of health worker movement is that they have highly relegated skill verification and certification systems. And this has been a blockage within mobility systems for quite some time. For decades even, the migration policy community has been talking about how we can increase recognition of skills across borders. It's quite complicated because it requires first having a credential that the employers from one country will trust, in a system for allowing recognition of skills that will create mutual trust on both sides. It also requires getting the buy-in of the domestic professional association. So for example, the Domestic Nursing Association to accept foreign workers with foreign credentials. So there is effectively a lot of negotiation that needs to take place. There's a lot of technicalities in aligning these systems, which creates a barrier, which is quite tricky. However, as Helen has mentioned, countries are right now finding ways around this. So we're seeing a number of countries like the UK and Germany, as well as the city of New York, which have been finding ways to speed up their accreditation process. So some of them are taking backlogs of migrant and refugee doctors and speeding up their accreditation. Some are even calling for those who are not pre-registered to those with foreign healthcare training, or even those who are just foreign medical students, to come and register, and they can receive temporary accreditation to start working in response to the COVID-19 crisis. So what we're seeing is that while this is a difficult barrier, and while we have much to learn about rapid recognition and vetting of skills, we're seeing that it's possible, and we're seeing that it can be done while having mutual trust on both sides. So the question again then is how to do that at larger scale. And then the final element that you need is intermediation and worker support. So you need a system that will connect the workers to the jobs wherever they're needed, and that will provide them support throughout that process, especially when you're talking, this is critical in any migration system, but especially when you're talking about in a crisis where the workers are expected to move rapidly, they probably have a number of their own kind of family issues to be tending to. You need to make sure that there's a system supporting these workers as they move around between jobs. So that's the first response that we could have in terms of allowing workers to move rapidly, and then I'll hand over to Helen for the longer term response.
All right, everyone, this is the last slide, so get questions ready. So one thing Rebekah already mentioned was that OECD countries are facing rapidly aging populations. This is something that isn't new, but potentially analysing the demand on health worker needs is new. In addition, you have a large number of countries around the world, particularly those in those critical shortage lists, who are going to be seeing massive demographic imbalances in the next 50 years, a burgeoning youth population. And honestly, even at current levels of economic growth, we won't see the type of job growth needed to be able to absorb all those new workers. So what's a way that in the long term, we could develop partnerships between these two types of countries to increase the global stock of health workers, so increase the number of health workers in both countries, and create those bilateral partnerships which satisfy that WHO code. So we would argue the only way to do that is through registered bilateral agreements. One such model, which you might have heard CGD talk about before, is the Global Skill Partnership. So it's been demonstrated already in a number of countries to deliver economic and health benefits for all involved, what's sometimes called a triple win. So we would argue this doesn't violate the WHO code and brain drain does not occur. And actually the WHO have agreed that as well, so don't be worried on that front. We would argue that this provides a way to increase the health worker stock, improve skills of all health workers, alleviate some of these concerns about integration, and crucially alleviate staffing shortages going forward, so that not only will we be able to tend for our aging populations, but we'll also be able to respond to those increased pandemics that Rebekah was talking about. So what is a global skill partnership? And there's obviously a lot more details about this that I can provide if interested. But essentially it's a bilateral agreement between two partners. The country of destination agrees to provide technology and finance to train potential migrants with targeted skills in their country of origin, and that's the crucial part, before they move. And they get migrants with precisely the skills they need to integrate and contribute best upon arrival. So the country of origin gets support for that training, and they get a new stock of non-migrants, which increases the human capital at the ground. So it's the only policy tool mentioned by name in the Global Compact for Migration, and we think it's a good way to try and realize Objective 5, which is increasing legal pathways going forward. But the defining feature of the Global Skill Partnership vis-a-vis other bilateral agreements is what we call the dual track models. That's what's illustrated on the slide. Basically, at the start or during the training, trainees can pick which track they want to go down. So either they stay in the home track and they reintegrate back into the local labor, I've got missing an R there, local labor market, and there's an away track for migrants. And those people may also get other skills training like languages and other cultural requirements. Now, obviously, all have the potential to earn more money and to increase their skills. And those who move have the ability to be able to migrate legally and safely under registered pathways. Now, this is currently being trialled around the world. One I'd mention is the Australia Pacific Training Coalition, obviously, in its third phase is really trying to increase the number of people in that away track, which will more closely resemble the GSP, and that's something we can talk through in more detail. It's also being trialled in a couple of places in Europe. But one thing we would love to see is more trials of this within nursing. And obviously this is very difficult to do given all of the things that we've already talked about, but we feel it's a really useful way in which sort of nursing or doctors or other types of health worker training can be deployed in countries of origin in order to increase the health worker stock in both countries. So, to conclude, we've already seen today that high-income countries face severe health worker shortages before COVID. They've become even more acute during COVID, and going forward, the promise of future pandemics, along with complications from aging societies, will increase this pressure. So we would argue that only by implementing proactive strategies to increase health worker migration, both in the short and in the long term, will we be prepared for what's to come. So thank you. I hope everyone's staying safe, and I really look forward to the discussion.
Excellent. Thank you, Helen. Yeah, we managed to fill the time wonderfully. That was a great talk. For the discussion, so I'm not sure who's new to Zoom and who is not. The way I would like to try and have it work, you can hopefully all see a participants list or a chat button or a raise hand button. If you can do that, please then raise your hand and I will go to you. I have a button here that allows you to talk. The webinar versus the normal meeting means that I have to moderate it in that way. So yeah, I'll wait for hands to come up and then click to you. If you can have your video also activate so we can see who we're talking to, please do that. And please, at the start of your question, also introduce yourself to the group. We have 26 attendees, a few from APTC, a few colleagues, and yeah, I'll kick it. So please, yeah, raise. We have four. Oh, it's not bumping up to the top. Who's raising? Please bear with me. Stephen House is allowed to talk. Talking permitted for you, Stephen.
Hello, can you hear me?
Yes.
Okay, great. I don't know if you can see me, but anyway, thank you. Thank you, Ryan, for organizing this, and thank you, Helen and Rebekah. That was a great talk, and it's good we're doing this. I guess I had two questions. One about COVID-19. I mean, I buy the case for more labor mobility for the health sector, but what do you think the impact of this crisis will be to really put up, increase the salaries for nursing, make it a much more attractive profession, and in general, de-globalize, try and be more self-sufficient. I just think, whether that's the right decision or not, I just think that's perhaps where governments will go. But the second thing is on, I've been following the schools partnerships for a long time and APTC and so on, but since I have the opportunity now to ask you, like, what about, there are some private sector models, like we know in the Philippines, there's a lot of private training of nurses, mainly for overseas markets, and it also happens in Fiji at a smaller scale. So what about, supporting them? I mean, either maybe they're sufficient, or maybe you just need to kind of spread that model around. Maybe it's more of a private sector initiative than a public sector one, and maybe that's also politically easier because it looks less like poaching, whether it is poaching or not. Thank you.
Over to you guys. We'll do one question at a time. Yeah, so over to you.
Okay, I'm going to briefly answer both, but then maybe Rebekah can chip in, particularly on the second, because she knows much more about private sector models than I do. So the impact of COVID on migration more broadly, quickly, what's interesting is I feel it could go one of two ways. I think either the increase in support for both migrant health workers, but also migrants in other sectors of the economy, which have been deemed as key or essential, could increase support for more migration going forward, both at a public level, but also at the political level. So that's something that, as I said, is currently being debated in the UK, or it could go completely the other way, which is exactly what you said. And that's something that obviously we're seeing in the US. Countries who maybe already wanted to limit migration are going to use this as an opportunity to keep borders closed or prevent more movement, both in terms of preventing the spread of future pandemics, which they may blame on mobility, but also in some kind of attempt to try and reduce the reliance on migrant workers and increase the number of roles available for locals. That's something we've been seeing in the agricultural industry in the US, that visa programs which were previously open to Northern Triangle participants have been cut in order to provide jobs for the newly unemployed. Now, a lot of our research obviously shows that that's unlikely to work, but it isn't going to stop politicians trying to come up with ways to try and reduce migration. And whether that be because they're against migration or because they want to be more nationalistic, as you say, is hard to know, and it's hard to know which way it will go. I think what's interesting there, though, is an argument that I've heard recently. If countries want to become more self-sufficient, they're still going to need to increase the stock of their health workforce, regardless. They full stop don't have enough workers. So there are obviously different ways of doing that. You could try and make the sector more attractive, and indeed they should. They definitely should be paying health workers more, and they should be improving working conditions. But given the numbers that we were looking at, I still don't think that's going to be enough to try and offset that difference. I may be wrong. Maybe if you double the cost, the amount of money we're giving to nurses, it will change that. But I would argue that these countries are still going to need more workers from somewhere, wherever they end up getting them from. On the private sector models, yeah, absolutely. We have never and would never argue that GSPs are the answer for migration, and that if you had 1,000 of them, the world would be better. It is an example of an innovative pathway. There are many others, including the private sector pathways that you talked about. I think two things there. One, it has to satisfy the WHO Code of Conduct. So as long as it is a bilateral agreement between two equal parties and that both are getting something out of this agreement, it's not just going into a country and taking skilled workers, great. I'm fully on board with proliferating more of those pathways. The second consideration is obviously exploitation. And that's a main reason why we would normally argue for government-to-government agreements, is that governments have more of a stake in trying to make sure that, one, workers' rights are being respected, and two, that development is actually happening in the country of origin and it's not paying lip service to best practice sharing or capacity building. But that's not to say it couldn't be done in a private sector partnership, as long as those things were being prioritized. Rebekah?
Yeah, two really interesting questions. Yeah, starting on the second, I guess. Certainly, as Helen said, I do tend to be a fan of private sector models. My background is actually on designing outcomes-based contracts for contracted out labor mobility systems. So I guess my answer would be, I don't see why they're not mutually compatible, really. I could easily imagine a GSP with private sector delivery that just had some kind of government project management and oversight. In fact, that might be an ideal model to me, but we can discuss that later. So I mean, I guess I don't necessarily see why those two things aren't even very mutually compatible. Yeah, I guess I'll stop there.
Okay, next up, I need to allow you to speak, sorry. Fergus Peace. I hope I pronounced your name properly. You're up, you're on.
Hello, hi, yes, you have. So, hi everyone, thank you. I also have two questions. One is quickly about the home track of the skills partnerships, which it seems crucial to kind of getting support and buy-in for that, is that, you know, some of these people who are being trained, not everyone's going to then migrate. So I was wondering what the kind of latest on that is from the different examples that you have seen on whether people actually do want to stay home. And then the other thing I was wondering about is the, Rebekah, you briefly mentioned the intermediation worker support aspect of the rapid response, which feels extremely important to me because, I don't know, I've never really heard of anything like this. I know there's sort of circular migration, but that's a kind of different pattern to people moving between different countries where they're a migrant in all of them. So I was wondering if either of you had more thoughts about how that would work, or kind of what models of existing migratory pathways or other kinds of things give you ideas about how you would make that work and make sure that people are kind of supported and not just being shunted between nursing roles, which may remain kind of underpaid and quite tricky to do in that sort of context. Yes, that is all. Thanks.
Great,
Do you want to start with the
Fergus.
first one?
Yeah, I'll start with the first one. So the thing I would say about the 3 GSP models that are currently in place is they're all in very early stages. So we're seeing some indications of how the tracks are working, but I couldn't say definitively what the implications are going to be. This is why I argue that we should pilot because if you pilot with 1,000 workers and it doesn't work, then you can change your model and you can deploy another way. If it works, you can scale. The evidence that we do have currently from both of those programs and other similar programs is that we are likely to see demand for both people staying and people going, with the caveat that the local labour market has to be sufficiently developed and sufficiently attractive for people to want to stay. So that's why we would argue to never do these types of programs in a local labour market that wasn't properly developed. Because if you train people for a particular role, they leave, they can't get a job, you've just increased their skills and you've told them about earning potential elsewhere, which could encourage more migration actually of those people in the future. That's not to be the case for health workers. Obviously the demand is huge, but as you say, I mean, the sector may not be desirable, it may not be, working conditions and pay might not be attractive, and it might be difficult to try and get people to stay. This is why there needs to be, on top of that health worker recruitment, active development of the local labour market, of institutions, both public and private, to be able to support recruitment into that local labour market. It also helps sometimes if the sort of migration opportunity is not incredibly attractive, and I'll couch that with saying, for example, the program that we have between Belgium and Morocco at the moment is not in nursing, it's in IT, but if people want to move, they have to learn the Dutch language. They get to go to the Flanders region of Belgium for 2 years, and then they have to go back. Not everybody wants to do that. We might say everybody wants to migrate, but I'm not sure that everybody wants to migrate under those set of circumstances. They may have reasons why they want to stay home. They may have family ties. They may want to practice in their own country. They may want to contribute to the development of their own country, or they may not want to take on those restrictions of the migration opportunity. So we've roughly seen actually in previous programs that about half of people want to stay and about half of people want to move. The exception obviously is programs in which that mobility is constricted in some way. And we've seen that a little bit with the ABTC. But I think that's why it comes down to design and piloting and scaling of what works and tweaking what doesn't.
Does that answer your question, Fergus?
Yes, it does. Thanks, Helen.
Cool. I'll disable you now.
Wait, so on intermediation though?
Oh, yes.
Rebekah had a point.
I know. Oh my goodness. My favorite topic as well. So, no, it's a great question, Fergus. And actually, I think in Australia, you have some great examples of how it could work in the PLF and SWP, in that you think about how it's a completely integrated system, really from end to end, right? And it's integrated between all the actors, sending country, receiving country, employer, worker, and with quality assurance and support for the worker throughout the entire process. So we're kind of just talking about that on steroids, really. Now, it gets really tricky when you talk about it at a global level, and I'll admit that I don't have all of the answers for that right now. I think that instinctually how I would think about designing that is maybe creating kind of a global rotating fund that employers who wanted to receive workers through this program paid into, and then have either one or multiple kind of global level contractors responsible for vetting the vacancies. Even this particular type of program would just be very logistically complicated in terms of even length of assignment and things like that. So vetting the vacancies, working out those logistics, moving the worker and making sure that they kind of had support, had accommodation, etc. And then you would need to kind of build vetting and minimum standards at each stage of that process. You could certainly tie that to outcomes-based contracts. You don't have to. But I think that we can think about really the PLS and SWP as pilot examples of how this could work at global scale, actually. It's just going to be a lot more complicated and a lot more rapid.
Great, thank you, Rebekah. While I wait for the next hand to raise, I can't see any. You're going to have to do that because I have to allow you to talk, so you can't just jump in as you normally would on the meeting. So please do press the raise hand button. I will use my exorbitant privilege as chair to have my question while we wait for a few more. It's just a small question, a pretty trivial one, but I'm just curious, on the one side where you had the home and away track, what's the motivation for actually having 2 tracks? My pride would be that, like, that everyone would be better being prepared to potentially be away sometime, making everyone migration ready, rather than only ready for a domestic market. Because the stuff that seems as a plus on the away track seems like it would be more helpful skills to have anyway for people further down the line as graduates. Is it purely operational in that it's a cost constraint for the providers, or what's the rationale for the 2-track rather than just mainstreaming the away so that every graduate has the potential to then be migration ready? Thank you.
I think that's a small question. That's what I spend most of my time defending. The dual track model was designed for 2 reasons. one, to mitigate brain drain. So there's no way that we could have designed a program that would have satisfied the WHO Code of Conduct that didn't include some form of workforce development and increasing the stock of health workers in the country of origin. And one of the only ways you can do that really is to train people for the explicit purpose of being plugged back into the local labour market. The second is political. It's very difficult to sell a migration pathway where you say everyone's going to move. It's easier to say, well, most people are going to stay, but if you will move, it's just easier to sell and get off the ground and get people to buy into it. What we would argue, though, is that this is explicitly designed so that the majority, if not all of the curriculum is exactly the same. So the people who are going through the home track are in effect being prepared for the away track without having the active recruitment and pathway formulated for them. So for example, the ICT training that's currently happening between Belgium and Morocco, Belgium has designed that curriculum because they had to. They put in place different skills that needed to be learned by the Moroccan trainees in order to ready them for the Belgian labour market. So in effect, they already have those skills in place. Now, just because they're not having their migration actively facilitated doesn't mean that it couldn't be facilitated in future or that they couldn't move on their own. But we would argue the whole point of having these 2 tracks is that you have a sufficiently attractive labour market and these people are plugged back into the labour market in their country of origin so that that desire to migrate is lessened.
That's helpful. Thank you. Next up, we have, sorry, my screen's not giving you a last name. Corinne Hinlopen. Please do introduce yourself as well. Thanks. Hello? Corinne? You're not muted. Is your microphone working? You're not muted. And you are allowed to talk, so it should work now. If it is not, maybe, oh no, sorry, I can't hear you, Corinne. I'm not sure anyone else can either. But if you perhaps want to type your question into the chat, that could still get us to a point where we're discussing it for the time being. If the microphone and audio is not working. Oh, here we go. Oh. I will wait to see if we can hear anything. You can all still hear me, right?
Yeah, we can hear you.
Yeah, okay, cool.
Maybe I'll speak to Andy's point that she's just put in the chat for now, and we'll see if Corinne, this comes back to a much broader question about how you finance such pathways, which is something we haven't probably gone into yet. And maybe Rebekah can talk a little bit about how she would see the rotating fund working and who would buy into that. I'm particularly interested in abusing my position as speaker to ask her a question about how it would work for government health systems. So how would the NHS pay into that and get public taxpayer support for recruiting migrant workers? On the funding of GSPs, this is obviously something we're looking into. Most of ours at the moment are in pilot phase, which means they're relatively cheap and funded often by development agencies, EU funding, World Bank funding, these sort of broader pieces of money. Obviously, that's not a sustainable model going forward, and the APTC obviously has been playing around with different ways of financing that going forward. Some schemes have private sector recruitment paying into that, so the private sector is actively paying for the workers that they will receive. And as Andy says in the chat, that could also provide for sponsored students in the domestic track. So the private sector could say, look, we'll pay X amount to get one worker, and we'll chip in, so to say, to pay for the training of someone within the country of origin. That could get around some of the constraints of private sector, even public sector employers in the country of origin, just not having the financial resources to be able to pay for that. The other way you could do it is through migrant loan or migrant sponsorship systems, which happen in a number of schemes around the world as well. We're actually running a paper right now on how you can finance such pathways, not necessarily to provide a one-size-fits-all approach, because it definitely doesn't exist, but to put out some of the different options that schemes could employ based on sort of best practice and lesson sharing from other schemes around the world.
So Corinne's first, I'm going to read the questions because I think only the panelists and myself can see the chat. The webinar is more censoring than the normal meetings are. So I'll just read the questions. The first one is, if I were a HW,
health worker,
and want to be part of such a global emergency response team, who would decide where I am deployed in times of outbreaks and on what criteria? Rebekah?
Right, so I'll take this one while I think Corinne is typing her second question, and it's an excellent question, Corinne. My answer would likely be to have a contracted out intermediation service. That service should be responsible for, that service provider should be responsible for collecting vacancies, or I guess requests for support would really be the right way to say it in this scenario, from health providers in places where there's currently an outbreak. And you can tie that to some criteria of outbreak if you want, or you could just say that when hospitals are saying they need help, we take that on good faith. And then I would say, and this would be a really, really tricky part in a rapid response team, you do want to have some vetting of what that job's going to look like. So what is that person being paid? What are the expected hours? What PPE is in place? What does the work environment look like? It's a really important part of placing a worker abroad, building out that quality assurance. I honestly don't have an immediate answer for how you would deliver that in a crisis scenario as part of a rapid response. That's really tricky. But I imagine you would just have to pay contractors to go perform those functions for you. And then of course you're going to need them to vet the workers as well. And that's going to have to be in line also with the countries using the service to make sure that the worker that you're vetting is meeting up to whatever standards they're currently using under the crisis modality. That's how I would design that. It's a lot of very tricky moving parts, but unfortunately it's always going to be complex.
And the second question, and then because we are now starting to get close to time, maybe Helen, you can speak to both as well, is that the discussion seems to be blurring between outbreak and non-outbreak situations. I wonder if high-income countries who are receiving health workers during the outbreaks will want to let go of their immigrant health workers in view of their already existing shortages.
Yeah, again, a good question. I think the way I would approach this is this happens all the time in circular mobility systems. So most workers who move on legal migration pathways do so in a time-limited way. So they're on contract for a certain period of time. Now, that's obviously normally a contract of years rather than maybe weeks or months, which is something Rebekah is talking about in terms of this rapid response. But it does already exist that migrants come in for a time-limited period of time, and at the end they leave. Now, that's obviously a contract between both the migrant and the state. If the state doesn't want to force them to leave, or the migrant doesn't want to leave, then that creates a whole nother discussion about extending migrant visas and justifying that worker staying within the system in which they're working. But most circular systems work rather well with people. I mean, we don't see very large visa overstay rates with a lot of circular migration schemes, and I wouldn't anticipate you do with this either, particularly if those workers are needed elsewhere in different countries that are starting to face the outbreak. But again, this is a new scheme, and this is why I always come back to piloting. We don't know what happens. Rebekah, sorry, do you want to chip in?
Can I chime in just quickly on that?
Yeah.
One of the reasons that we see that when circular migration pathways work, one of the ways that they work is by making future migration contingent on leaving in the time frame that you said you'd leave in. So actually, I think this question is really interesting. And one of the things I would love to kind of add to this scheme is you get some sort of certification of your having participated and having provided this service, and that you can use that credential, or maybe even that gives you favorable migration status for following. I love that. We should adopt that.
Mm.
Do we have one last question? We have 2 minutes left. Looking for a hand to raise. Waiting. I see one. It is, okay, I'll allow you to talk. Please introduce yourself.
Hi, it's Beth Orton from Development Policy Centre. Thank you for the presentation in our afternoon and your other times of the world. I'm interested in the idea of workers moving from different countries, more not so much the partnerships between two countries, but moving around to a number of different countries. So this sense of permanent temporariness and how that challenge can be mitigated, because particularly, I mean, we keep referring to COVID-19, but we have seen the vulnerability in a number of countries around of temporary workers, and COVID-19, there might be another shock or another incident that affects these temporary workers, health workers in different countries. And if we're encouraging this permanent temporariness of these workers, how do we mitigate the vulnerabilities of things affecting these workers in their country at that time? Does that make sense?
I think so. And certainly, yeah, when you're moving people around frequently and rapidly, there's a lot of risks. So you have to build a lot of support into that system. I mean, there's precedent for it, right? Like Doctors Without Borders exists. You have obviously just a large humanitarian workforce. So there's precedent for a system like this. What I don't know is what support is built into those systems for the workers. But I would think that's why you want such a robust intermediation and worker support system tied to it. And again, I actually point back to the example of the PLF and SWP, which I think are great examples of where, all of the jobs are vetted, the employers are vetted, people are checking in with the workers, there's grievance redress systems when things go wrong. There's even, I think, just kind of more social support to the workers, because I mean, you can imagine migration is always difficult, no matter what circumstances it's under, but under the circumstances we're describing, it would be incredibly difficult. So you want even just a lot of kind of community support to that workforce. Yeah, so I think it's just, at least to me, about building out that support system for the workers would be how I would look to reduce those vulnerabilities. Well,
Helen, anything? Well, great. With that, we are at time. I would like to thank both of our speakers for joining us. Normally in the meeting, we would do a group round of applause, but I'll just do that myself here for the time being with Ari, since you have everyone too. So I would encourage everyone who has tuned in, however, please do investigate this stuff further on CGD's website and on their blogs, and check out their papers. Keep an eye out on our website and our blog for more COVID and migration content, and also keep an eye out for more virtual talks, which this will be the one of. I think we will be doing many more. I very much hope that you will join us for them as well, and please do stay safe. With that, I will take this meeting to a close. And yeah, thank you again to both the speakers. That was fabulous. I'm very glad that you could take the time in your respective wild hours, Helen being first thing in the morning and Helen and Rebekah, it's very, very late for you, I know. So yeah, big thank you to you both. We all appreciate it over this side of the pond. Yeah, take it easy.
Thanks for having us.
No worries.
Thank you.